This is my professional education presentation on the topic of labor induction. In this presentation, we'll discuss how we as nursing students will meet the needs of our clients, such as the physical care of the client and pharmacological management, and also the psychosocial care of both the client and the family. So what is labor induction? It's the stimulation of uterine contractions before the onset of labor, with various types of methods, all for the purpose and goal of accomplishing vaginal delivery. In what cases is a labor induction needed or indicated? Ultimately, it's decided by the healthcare provider, but indications for labor induction include gestational diabetes, preeclampsia or eclampsia, premature rupture of the membrane in which the water has broken but labor has not begun, chorioamniocentesis, postpartum pregnancy, fetal growth restriction, placenta abruption, certain medical conditions such as kidney disease or obesity on part of the mother, and oligohydramnios. With labor induction, there are contraindications to these procedures. For example, client refusal, placenta previa or vasa previa, a floating fetal presenting part, prior uterine incision that would preclude labor, active genital herpes, a acute non-reassuring fetal heart rate status, and absolute cephalopelvic disproportion. The patient should also be educated about the risks of labor induction, such as the increased likelihood of a needed C-section, a longer hospital stay which could affect their financial status, a greater need for pain medication, an increased risk for infection, and complications such as during delivery, such as uterine rupture, placental abruption due to the intense contractions. The patient should also be educated that labor induction sometimes does not work, and that a failed induction would mean that another method of induction would have to be tried or a cesarean delivery would have to happen. The chance of a cesarean delivery is greatly increased for first-time mothers who have a labor induction, especially if their cervix is not ready for labor. Prior assessment should be made by the healthcare professionals, especially the nurses. The two main factors of the prior assessment include fetal maturity and cervical readiness. Fetal maturity, what is it? It is if the mother is term. A woman who is considered preterm should not undergo an elective labor induction. The other factor is cervical readiness. This is done through a cervical exam to help determine if the cervical changes allow for induction. In other words, to see if the cervical characteristics are ripe enough. The Bishop score is used to determine if the client's cervix is ripe enough for induction. The factors of the Bishop score include the dilation of the cervix, position of the cervix, percentage of the effacement, the station of the fetus, and cervical consistency. The lowest score is 0 and the highest score is 13. So what are the therapies of labor induction or procedures? The three primary ones are stripping the membrane, mechanical dilation with intracervical changes, and oxytocin or pitocin infusion. Stripping the membrane. A physician or CNM would insert a gloved finger into the internal OS, rotate their finger 360 degrees twice, separate the amniotic membrane in the hopes of releasing prostaglandins to stimulate contractions. This procedure is known to be very uncomfortable, and the patient should be informed it can result in cramping, painful contractions, and vaginal bleeding. Mechanical dilation with intracervical changes is when an intraventricular catheter is inflated in the cervix to cause mechanical dilation. This method has proven to be very effective without cause of infection, fetal tachysystole, but does cause immobility for the patient due to the risk of displacing the intraventricular catheter or balloon. Oxytocin or pitocin infusion is the most common method of labor induction. This is done to initiate uterine contractions and enhance ineffective contractions. How this is done is a primary line of 100 milliliters of lactated or ringer solution of IVS started. 10 milliunits per milliliter of oxytocin is started on a second line. Then the prescribed dose is calculated. The goal of this induction is to achieve contractions every 2 to 3 minutes, lasting 40 to 60 seconds. The nurse and patient should be educated that excess oxytocin levels can cause maternal hypertension, tachysystole labor patterns, uterine rupture, placental abruption, rapid labor, hyperbilirubinemia, and fetal bradycardia. Because part of the client's physical experience is a medical treatment, this is the medication by classification for oxytocin. The classification is oxytocics. The indications are inductions of labor at term, facilitation of threatened abortion, and postpartum hemorrhage control for placental expulsion. The pharmacological actions are stimulating uterine smooth muscles, producing uterine contractions. It is also known that it can cause vasopressor and antidiuretic effect. The desired effect obviously is induction of labor and control of postpartum bleeding. Administration is done IV and IM. For IV, the onset is immediate, the peak is unknown, and the duration is approximately 1 hour. For the purpose of stimulation, the rate is 0.5 to 1 milliunits per minute, increased by 1 to 2 milliunits per minute every 30 to 60 minutes until the desired contraction pattern is achieved. For the postpartum hemorrhage purpose, 10 units at 20 to 40 milliunits per minute is the rate. For IM administration, the onset is 3 to 5 minutes, the peak is unknown, and the duration is approximately 30 to 60 minutes. This is administered with 10 units after the delivery of the placenta. There are contraindications and precautions with this medication, such as hypersensitivity and anticipated non-vaginal delivery. It needs to be used cautiously for first and second stage of labor. The nurse should know that infusion over 24 hours has caused water intoxication with symptoms such as seizure and coma, and maternal death due to the antidiuretic effect. Adverse reactions and side effects include fetal hypoxia, maternal hypotension, hyponatremia, increased uterine motility, painful contractions, and decreased uterine blood flow. As nurses, we need to assess the characteristics, frequency, and duration of uterine contractions. If contractions occur less than 2 minutes apart, more than 50 to 65 millimeters of mercury, lasting longer than 90 seconds, and if there are any significant fetal heart rate changes, the nurse needs to stop the infusion, turn the patient to their left side, and notify the provider immediately. They are also to monitor maternal blood pressure and heart rate frequently and fetal heart rate continuously. Because water intoxication is a possible side effect, a nurse should assess for drowsiness, confusion, headache, and urea, and if these symptoms are present, notify the provider. Possible lab tests include an electrolyte test for possible hyponatremia and hypochloremia. We'll discuss patient education more, but for now, the patient should be educated that expected contractions are similar to menstrual cramps after administration has started. The patient also experiences psychosocial factors such as concerns, anxieties, and fears. The nurse should also pay attention to the family to make sure that the family is coping okay and assess the family dynamics. The primary psychosocial experience may be anxiety. This is the vague, uneasy feeling of discomfort, which is a normal response. This can be related to the perceived threat to the client, the fetus, a situational crisis, or any unanticipated deviations from what is expected. The patient and family may feel apprehension, a decreased self-awareness. The patient may also feel feelings of inadequacy because of their physical body not being able to perform labor, and have specific concerns or increased tension. The patient may also have a knowledge deficit because of the lack of exposure or unfamiliarity, or have misinterpretations of labor induction. We'll later discuss key points in the psychosocial care of the client and family. What are the key points, though, for the physical care of the client? As discussed earlier, it's important to assess the fetal heart rate continuously, assess the frequency, duration, intensity of the contractions, accelerations, and any decelerations, the uterine resting tone every 15 minutes, record any client activity such as position change or vomiting, procedures done in the past, any administrations of agents or medications, and assess cervical dilation as needed. It's important to obtain a baseline and monitor maternal blood pressure, heart rate, respiratory rate, temperature, and pain level. The nurse should place an external fetal monitor 20 minutes before the induction to obtain a fetal heart rate baseline. They can also perform a non-stress test to test fetal heart rate in response to fetal movement. It's also important to evaluate the urine output because of the antidiuretic effect of oxytocin above 20 milliunits per milliliter. Change the position of the client with the back of the head of the bed elevated and a pillow or wedge placed under one hip. Patient safety and satisfaction are very, very important. How can the nurse address the psychosocial care? They can fully explain the induction procedure, whether oxytocin, an amniotomy, mechanical dilation, or stripping of the membrane, and answer any questions the client or family may have. What this does is provide a sense of control, participation in active decision making, and decreases the family and client's anxiety. The client needs to be offered as much autonomy as possible and be offered telemetry units enabling the patient to ambulate, sit in a rocking chair, a birthing ball, or the option to shower or bath. All these minor interventions build up the autonomy of the patient, decreasing their anxiety. The patient should be given encouragement, kept informed of the progress. The nurse should thoroughly and continuously listen to the client's comments that indicate any low self-esteem, because this indicates that the client's having negative reflections because of her lack of abilities. The nurse should continuously provide instructions in simple breathing techniques, assist and encourage the client to change any position, and to establish a rapport with the client and the family to keep them feeling comfortable to ask any questions. The nurse should also advocate for any patient needs or concerns. All of this information and methods should be given in a kind, informative way and be given with respect and privacy on the part of the patient. Excellent resources for the patient are the March of Dimes, American College of Obstetrician and Gynecologists, American College of Nurse Midwives, Association of Women's Health, Obstetric and Neonatal Nurses. These references will keep the patient informed about the physical care that they will receive, including the pharmacological treatments. This information will also help benefit their psychosocial aspect by giving them information that they need to make informed decisions and to decrease their anxiety.